providing our care, and it's the highest level of epilepsy center that can be awarded. Dr. Ben-Solomon leads a very large team to try to provide this kind of care. And you heard the names of just a few of the people that were involved in Joey's care. In addition to Dr. Ben-Solomon, Dr. Khan, a child neurologist who's also an epileptologist, Dr. Pittman, his neurosurgeon, Dr. Sudhakar, one of our neuro-ophthalmologists who checks vision and the way surgery might affect Joey's vision. Luckily, there was no effect at all on his vision. Dr. Dan Hahn, our neuropsychologist, our coordinators, Micah Philpott, who I think is still back there, Rachel Ward Mitchell, our EEG technicians, our technologists, our epilepsy nurses, our resident physicians. This is an entire team that's assembled to work together to try to provide the best possible care for our patients, and Joey is a great example of that. In addition, now in the Kentucky Neuroscience Institute, we really are trying to not only integrate all of these various aspects of our clinical care, but also our other missions, that is providing cutting-edge research to try to figure out better ways of treating children with epilepsy and with other neurologic conditions, as well as our education mission. I mentioned our resident physicians, who are not only trainees, but also our frontline care providers, but as well as all of our other efforts to educate other physicians, other healthcare providers, and as we're doing here today, the public. So again, Joey Smith, thank you so much for joining us today. We really appreciate it.
Thank you, Dr. Goldstein. At this time, we'd invite questions from the media, and we ask you to just direct them to either Erin, who is Joey's mom, or Joey, or Dr. Goldstein, or to Dr. Ben-Solomon. Anybody have any questions at this time? Cheryl.
Joey, I just want to say, you are really smart, well spoken. I mean, I am in awe there, because a lot of young people your age would be taken aback by all the cameras and not able to speak extemporaneously, and you did an absolutely marvelous job. I just wanted to ask you what it is like for you to wake up every morning and think, I don't have to worry about this anymore.
I think it's a relief, because normally whenever I wake up, whenever I had seizures, I was scared, like, is it going to happen today? How many am I going to have? Is it going to be bad, or is it going to be okay a little bit? But after the surgery, I feel like I could just wake up and be happy for the rest of the day, don't have to worry about anything. And that's pretty much what it feels like.
And what sports are you looking forward to getting back into?
I like to play soccer. Sometimes I like to play baseball in the backyard or something, because I can really hit the ball and almost hit my sister.
I'm sorry, you can really hit it.
I can hit it hard enough and scare my sister so she tries to hurt me.
That's always the worst, though. Dr. Ben-Solomon,
Yes.
I just wanted to ask, how many children are actually good candidates for this sort of surgery? I mean, do you have an ideal candidate? How often is it done, and what are the age ranges?
Well, we don't, any child with refractory, an individual with refractory epilepsy should be considered. Not everybody's a candidate. Usually if a patient who has epilepsy has failed 2 anti-epileptic drugs, 2 anti-seizure medicines at decent doses with a fair trial of these medications, the likelihood of adding a third one really, it's going to be very unlikely that it's going to render them seizure-free at that point. About 3% of patients become seizure-free as we add the third one, if the 2 have not responded to the 2 anti-seizure medications. But now, not everybody's a candidate, but if somebody's drug resistant, they definitely should undergo an evaluation. Some patients may have what we call eloquent cortex in the area of interest. That means that there is function that is not negotiable, that we cannot remove. And now there is a device called the responsive neurostimulator that can be placed, but it's not approved for children, for instance, so this won't be an option for them. But I think what everybody needs to keep in mind is that the surgery has to be tailored. So for the patient and the type of epilepsy they have. In the case of Joey, we used subdural grids or strips. But not everybody who undergoes brain surgery will require these, for instance. And now for the exact number, I can tell you that there are not enough surgeries. There are about probably more than 100,000 in the United States candidates for epilepsy surgery. So more than 100,000. But there are about 2,000 to 3,000 surgeries in the United States that are performed.
Questions from anybody else?
To the doctors, is how many days has Joey been seizure-less? And when was the exact date of the surgery?
So the surgery was in mid-January, and so it's been 4 months now.
And how long was the actual surgery?
The surgery lasted several hours. I mean, I wish Dr. Pittman was here. I think probably 3 or 4 hours for the second surgery, between the time of anesthesia to when the patient is awakened. When these were placed, Joey had these for 6 days implanted, these electrodes. So for a full week, he had these implanted while we recorded seizures directly from the brain. And he underwent 2 brain surgeries. So the first surgery, Dr. Pittman implanted these electrodes, and then he was sent to the epilepsy monitoring unit, where we recorded seizures and performed brain mapping. And then after a week, he went for the second surgery, which is removal of the electrodes in the area of interest.
Is this how would you categorize this, as an experiment or a cure? Or is this a cure?
Well, for now, he's seizure-free. Of course, only time will tell us. Hopefully, it's going to be forever. But yeah, the likelihood of obtaining cure is probably higher with epilepsy surgery than with medications, especially if somebody has failed, as I mentioned earlier, a fair trial of anti-epileptic drugs.
In the surgery, he had a lesion that you removed. Is that correct?
Yes,
And
yes,
then
that
you
Dr.
removed
Pittman
parts of his
removed.
brain?
Yeah, so Dr. Pittman basically, based on the mapping, he had to avoid certain areas because there was function. There was motor function and visual function. So he had to work around these areas to avoid any deficits at the time of the surgery.
Just to clarify, in case you a little unclear, when seizures occur, they can come from many different areas of the brain. The way that we generally start evaluating it is with electrodes that are just placed on the scalp. That's the electroencephalogram, the EEG. But that only can give a rough approximation of where seizures may be coming from. So with that information, these electrode grids can then be placed to try to much more precisely identify where the seizure is originating from. That's the part that you want to remove, but you don't want to remove areas of the brain that are serving function, such as vision, speech, movement. So that's where this really advanced multidisciplinary team comes into play, working with the clinical presentation, the EEG and the electrical information, then very carefully planning the surgery so that only the area that's causing the seizures is removed and the other areas of the brain aren't touched.
So was this the first surgery of this type done here?
No, actually, no, this is not the first. And I heard earlier experimentation. No, it's not an experimentation. This surgery actually has been performed for several years. But when we discuss it with patients who have epilepsy or even other physicians, everybody seems to be surprised. And while this surgery has been performed for several years, actually.
What are some of the side effects, or do we know from the surgery?
From the surgery, there were several potential risks that are discussed with the patients by the neurosurgeon, there was a risk of pain, of course, bleeding, infections, but the neurosurgeons, the team works in a very sterile field to avoid all these, of course. But all these side effects are discussed prior to surgery, like any procedure. They're discussed.
And one of the major concerns is that the surgery could remove an area of the brain that's serving some function, such as I said, vision, speech, thinking. The data for this are actually incredibly encouraging, especially in terms of thinking, school performance, those types of activities. The data suggests that actually improves after the surgery, not worsens, but improves on average after these operations. You would think that removing a portion of the brain could create problems thinking or problems with some of these other activities. But when it's done very, very carefully, not only do you not have those larger types of deficits, but actual cognitive performance, the way people think, actually can improve for a variety of potential reasons.
So if the surgery has been performed here for years, are you just finding that people are not, that people don't know about it, that people don't come here to seek it?
Yeah, absolutely. I think there is. I think we need to educate the public and other physicians that first surgery should not be for epilepsy. Should not be considered a last resort. I see frequently patients who had epilepsy for 20 years, for 10, 20 years, and they come to see me. They're finally referred, and when I discuss this with them, and they think it's wow, they're just amazed, and they just can't understand that this has been present for so many years and nobody had discussed that with them. That even some of them haven't even known that there was an option of brain surgery.
Julie or Joey, you're back at school. How are your grades?
About the same.
It's okay.
I think he's enjoying now. He's enjoying things. Is that right? He's going to focus next year on the academic performance.
What's your favorite subject?
Probably science or reading.
Anyone else?
Joey had told me he used to stutter and now he does not. Would that be due to the surgery or the medicine?
I don't think. Well, it might have been the medicine, maybe. You think so?
It could be the fact that probably you don't have seizures. Having seizures, having that many frequent seizures can disrupt brain function, and that's why we see patients that have an improvement in their language and their cognitive abilities just because there is not this short circuitry to the brain that's disrupting brain function on a regular basis. Because we haven't changed the medicines yet, so Joey stays on his 2 anti-seizure medications at the same dose for now. And if he continues to do well, then we will decrease the dose and eventually discontinue, but this only time will tell us.
Any other questions? Well, we thank you very much, and we will have our speakers, including Mom, Erin Smith. We will have Joey. We will have Dr. Bensalem-Owen and Dr. Goldstein available to you individually. We thank you all for coming and sharing in this good news that we're announcing today at UK. Thank you and have a great day.
Thank you. Thanks. Thank you.
Great job.